In this video, I'll talk about the injury that led to my ACL tear, the imaging findings, the current research about osteoarthritis rates after ACL injury and reconstruction, what is important to optimize before surgery, as well as the different graft options for ACL reconstruction. For those of you that don't know me, I'm currently in my second year as a doctor working at Burwood and Christchurch hospitals, and sport is a huge part of my life. In the past, I've competed in powerlifting with a best squat of 290 kilos, bodybuilding, Brazilian Jiu-Jitsu where I'm a blue belt, calisthenics, and golf, where I'm currently a plus 2.2 handicap, but I've previously been as low as plus 4.8, and I've played as the #1 amateur for both the Otago and the Canterbury province in recent years. I've also created an online course for the physics paper Physi 191 in Health Sciences first year at Otago University, where I show you step by step how to solve even the hardest physics problems. If you or someone you know is going to Health Sci, then go to my website to check out my free module. In May this year, I ruptured my ACL while bouldering. I reached the last hold, but ended up losing my grip. Because of the way that I was holding on, my whole body started to rotate as I fell. When I landed on the ground, all the kinetic energy I had generated from a height of 2.5 meters all went through my knee. I felt two distinct crunches in my knee, crunch crunch, and could feel my knee had gone beyond what was normal. There was an immediate onset of pain, and it was probably one of the most painful experiences of my life so far. Thankfully, the other climbers and the staff there quickly called me an ambulance and I was able to get to hospital. The knee quickly became very swollen and I could only move my knee through 5 to 30 degrees of range of motion. On physical examination, there was no obvious laxity. Thankfully, the x-ray showed no fractures, but a joint effusion, aka swelling, was seen, which suggested a ligamentous injury. So they referred me for an MRI. 3 days later, the MRI showed a complete rupture of my anterior cruciate ligament, or the ACL. It also showed large tears in both my medial and lateral meniscus. The lateral meniscus was a bucket handle tear. Here's the sagittal or from the side view of my knee MRI. The ligaments are dark on MRI, and here you can see the posterior cruciate ligament, the PCL, running between the tibia and the femur. These dark lines here are the fibers of the ACL, which are lying very horizontally. When the ACL is intact, the fibers are much more vertical as they attach to the femoral condyle. In my case, the ACL has torn completely and has no proximal attachment. You can also see the white signal which is showing the meniscal tears. Normal healthy meniscus is dark. 10 days post-injury, I had an appointment with my surgeon where we discussed surgical management. I had thought about conservative management, but as I was quite active and young, I thought it would be best to have my ACL reconstructed. My biggest fear is developing early knee osteoarthritis. I wanted to know whether ACL reconstruction would reduce the risk of developing osteoarthritis. The research didn't seem to support that and showed similar rates of arthritis. Having surgery does not make a significant difference to your rate of developing osteoarthritis over the long term. Theoretically, the lack of an ACL could mean that the tibia could slide forward relative to my femur and cause damage to the meniscus and cartilage if I was to expose my knee to high twisting and decelerating forces. Having strong hamstrings can compensate to a large degree because they help to prevent motion of the tibia forwards when the knee is bent. That's why it's so important to develop strong quads, hamstrings and calves, because these muscles help to stabilize the knee joint and lessen the load on ligaments, such as the ACL. Some American football players have had MRI scans showing that they have no ACL, yet they were able to play without any effect on their performance. This is likely because their leg muscles were so strong and the quads and hamstrings were more than capable of compensating for the deficient ACL. The two main graft options used to reconstruct the ACL are the patella and hamstring tendons. With the patella graft, people can develop kneeling pain because the graft is taken from the area you kneel on. There is also the very small risk of patella tendon rupture. The hamstring graft avoids the risk of kneeling pain, but can cause decreased hamstring strength. This can be overcome with good rehab to regain this. They have similar yearly failure rates. Patella tendons have a failure rate of 1.2% and hamstrings 1.7%. Most cases of re-rupture after reconstruction are due to people going back to sport too early without adequate rehabilitation. While waiting for my surgery, I regularly went to the physio and worked diligently on regaining range of motion, especially full extension, as this is very important for function. Having full extension prior to surgery is paramount. A locked knee can be due to a torn meniscus which is blocking full extension, but more often it is initially due to swelling, and later on due to both impaired quadriceps activation and hamstring shortening or contractures. So it is important to do active isometric quad contractions, known as quad sets, as well as passive knee stretches by propping up the heel on a towel or cushion. It is important to do these exercises and stretches frequently and at a low intensity. Muscles will shrink as soon as you stop using them, and also the brain will quickly forget how to activate these muscles if you're not constantly sending signals to them. If you want to have a speedy recovery while minimizing complication, then maintaining muscle strength, size, and neuromuscular activation, as well as gaining full extension, will have a huge impact. By 4 weeks post-injury, I was walking without crutches. I had regained full extension with a little bit of hyperextension, similar to my uninjured knee. I was still very careful and did not do any running, jumping, or twisting exercises. At 2 months after injury, I went in for my ACL reconstruction. My surgeon and I decided a patella graft would be best for me. The surgery would involve taking out the middle third of my patella tendon and then passing it through a tunnel that was drilled through my tibia and femur in order to reconstruct the ACL. My surgeon also planned to repair the medial meniscus with a few sutures, as it looked to be amenable to repair. I had the surgery under general anesthetic. Thankfully, everything went well. My surgeon told me that he had been able to repair my medial meniscus with a few sutures, and the ACL reconstruction had gone to plan. Now it was time for the recovery. In my next video, I'll show you my recovery timeline, progress pictures, what went wrong, and everything else along the way. See you there.